So now you guys will finally be able to figure out what the heck is wrong with me and what meds I should be going on, right? Hopefully. First thing we're going to talk about is major depressive disorder and the medications we're going to use for that. You'll see there's a lot of crossover with a lot of these medications. So just because we talk about things for depression doesn't mean you don't use them for lots of other indications. We already mentioned the tricyclic antidepressants used for neuropathic pain. You'll see some antipsychotics being used for treatment-resistant depression. You'll see anti-epileptics being used for mood stabilizers and all in between. So with these kind of centrally acting, neurologically acting drugs, there's a lot of crossover here. So we'll talk about a lot of drugs and you'll see them pop up very frequently from here on out. So again, we know this is affecting a ton of people. We know that nowadays we have a lot better drugs than we used to. So for instance, back in the day, we were using things like monoamine oxidase inhibitors, which have a ton of side effects, have a ton of dietary restrictions. Then we had things like the tricyclic antidepressants, which had fewer side effects, but were still pretty nasty in some regards. And then nowadays we have pretty safe medications for the most part, especially when you worry about depressed patients. What is something that they are at risk for? Suicide. And what do they frequently take? Their medications, right? So back in the day when you were giving something like a tricyclic antidepressant, that can have significant cardiovascular effects and significant effects on the CNS. My old boss at the Poison Center, he said they would have 4 beds in the ED that was just set up for intubated patients who would overdose on their tricyclic antidepressant, right? It was a constant revolving door of that stuff. So nowadays, if we can give them safer medications that even if they overdose on, they are rare to really get into too much trouble. We'll talk about some risk for that, but it's a lot safer for them in a lot of ways. And so that's kind of the nice thing about the therapy we have nowadays. It's really important that we also look at treating not only the depression, but also the anxieties as well. And one thing I've kind of found with a lot of people is that their depression, quote unquote, is really just a major manifestation of their anxieties. And so you'll see a lot of the antidepressants we have also being used to treat a lot of those anxieties. Things like OCD disorder or just OCD can be used for that as well to help manage a lot of those anxieties. I actually have OCD so bad I have CDO, but that's neither here nor there. The other thing you might see is that some people just say, well, these antidepressants don't really work. And the problem is it's very difficult to determine what truly is effective therapy because a lot of the trials were confounded with things like placebo effect. So even if I have a really depressed patient and I give them sugar pills, they have a high percentage chance that they're just going to feel better on their own. Right, because there's a lot of mind over matter kind of things where they just feel like they're doing something for their depression. They feel like they're doing better, right? And so a lot of that can be tough to deal with, so there's a significant placebo effect, and there's also kind of poorly defined outcomes in a lot of those trials. So it's hard to say whether just how effective a lot of these drugs are. In a lot of cases, there's not good head-to-head trials to say which one is necessarily better than the other. So very frequently, it's kind of more up to what commercial did you see last, or which one is your insurance covering, and then you kind of have a better idea once they have side effects and see how well it works to switch over to something else. So. Again, it's important when you're managing these patients to assess for secondary causes for their depression. So, if they're having hypothyroidism or if they have inflammatory conditions, this can all exacerbate depression. And I mentioned here the medications because this can be pretty significant. So do a good medication history, make sure none of these are on board because these could be a significant kind of smoking gun as to what their depression is being caused by. So for instance, isotretinoin, otherwise known as Accutane, that can have a significant effect on a patient's mood. That can cause depression, so that can be a big one. Certain anticonvulsants can do this, like topiramate or levetiracetam. Cardiovascular agents and also hormonal therapy can all affect your mood. So again, evaluate this, make sure none of these are kind of the obvious players here, and potentially just by switching their medication regimen, you can fix a lot of their depression, anxiety issues already. And so, again, this is also an underdiagnosed and undertreated problem, and we see that a lot of patients with major depression, a significant chunk of them end up trying to commit suicide. And so very frequently, they've used a lot of their own medications or other people's medications, and so this is where we get a lot of calls to the Poison Center for these patients who have multiple drug exposure after an intentional attempt to harm themselves. So it's a big thing that we dealt with a lot in my realm of tox. Do you have a question? No? Okay. All right. So again, with the anxieties, we know that these can be characterized in several different conditions. So again, most common probably just generalized anxiety disorder. There's lots of other ones, and you'll see that a lot of the antidepressants we're going to be using for this will help with their anxieties as well. So a lot of patients I've talked to have kind of described it as just feeling like it's like, yeah, I kind of when I started my SSRI, and it started to kind of kick in as like, yeah, I had all the stuff to do, but I didn't really care about it anymore, right? Just kind of have a more kind of laissez-faire kind of attitude as compared to things just like constantly just nipping at you, be like, hey, you didn't do this today, you didn't do that today, just things like that just kind of feed on your anxiety. So that's kind of one of the big benefits that they see with that. Looking at the pathophysiology, you'll find that a lot of the antidepressants that we deal with, we don't really have a good idea how they work. We know what they do, we don't really know how they work for depression. And so there's been lots of different theories about how depression comes about. Some people thought it was due to depressed levels of some of these monoamines. And so that includes things like your serotonin, otherwise it's going to be abbreviated as 5-HT, norepinephrine, and also dopamine. So if people thought you had low levels of these neurochemicals, if we were to increase them, that should fix your depression, right? We also saw this in regards to a certain antihypertensive drug, an old drug we don't use anymore called Reserpine. And Reserpine basically made you just deplete all of these monoamines. And they actually saw that a significant number of those patients ended up developing depression because of that. So that's where kind of that theory really came from. But again, you'll see that we don't necessarily know how these drugs are working for depression, but we do know that they're effective, or at least they appear to be so. Other big things to note is that antidepressant effects do not occur instantaneously. This is the biggest patient counseling point you can make to them, is that therapeutic effects can take weeks, up to 6 weeks before you can really say whether or not a drug's going to work for you, right? So they'll start taking the drug, they'll be like, I'm not feeling any better, this stuff is terrible, I'm going to go off of it, right? Especially if they're dealing with side effects, they're worsening their quality of life before they even get better from the depression standpoint. It can make compliance a big issue. So let them know that. We also are going to run into some issues where we see that there could be some changes in downstream effects. So a lot of the drugs that we use nowadays increase levels of your catecholamines, like norepinephrine, serotonin. But what are the downstream effects of that? What happens with things like receptor occupancy, gene transcription, things like that? And so nowadays we're looking more at adaptive or regulatory changes that occur downstream from just the simple increasing levels of serotonin, right? So we're seeing there's probably, it's a lot more complicated than we originally thought. And so now we're still trying to figure out how these drugs are really working for depression. So our goals of therapy when we're treating these guys is going to be reduce their symptoms of acute depression, facilitate level of normal functioning, and then try to prevent future episodes of depression from coming back. All right, so main 3 phases of treatment that you'll see with these guys is that first you have the acute phase, usually the first 6 to 12 weeks or so when we're having remission of symptoms. From then on, you're going to have the continuation phase, say 4 to 9 months, where you're eliminating any residual symptoms and then prevent recurrence. And then you finally have your maintenance phase kind of from there on out. And so, what happens, do you think, to a patient who's having a severe depressive episode? They go through this acute phase, they kind of get over the initial hump, and they feel better. What do you think they do? They stop taking their meds, right? And so then what happens? They go back right back into where they were before. And so again, another good patient counseling point is that just because you're feeling better, it's probably because of the meds. You should probably just stay on them and keep going. And a lot of patients may be on these for the rest of their lives in some cases. So again, compliance is always going to be a big issue with these patients. So especially if you've had more recurrent episodes, this would be a better indicator you probably need to be on this long term. And so just talking to these patients, making sure they're being adherent is going to be critical for their success. So non-pharmacologic therapy, things like psychotherapy are going to have good synergistic effects, especially with antidepressants being on board. A lot of people who are, have depression, they don't want to talk to people about it. I think a lot of that stigma is starting to kind of recede now. So I think, psychotherapy is great for a lot of people. You have other things like, electroconvulsive therapy that can be used in some treatment-resistant cases. And I also put this repetitive transcranial magnetic stimulation. This thing is actually kind of interesting. My friend who is a paramedic actually got a job at one of these kind of holistic kind of care centers where he actually was the operator of one of these transcranial magnetic stimulation devices. It was actually kind of interesting seeing his patients come in, how they actually had pretty significant improvements in their depression over time, just by basically putting a device on the front of their head. I don't know, have you guys covered that before? Basically what it is, you put a device and basically it kind of goes on the front of your head and kind of, you guys just beams these magnetic fields through your brain, and for whatever reason, it works. So they come in, maybe do like an hour-long session or so, and over the course of several weeks, they would end up having pretty significant effects. There's actually some decent research out there talking about its efficacy. So again, all these things can work in conjunction with the antidepressants. Oftentimes, it's not enough just to say, here, take this pill, you'll feel better, and that's it. Like, that may not be enough for a lot of people. So just keep that in mind. Okay, but we're here to talk about drugs, so let's give them drugs, right? All right, so again, with the antidepressants, we don't know really who's going to respond to what. And so in the studies, we saw like 30 to 40% of people actually responded well to placebo. They had improvement in their symptoms. And so again, we don't really know if this is what we're seeing is just placebo effect or if the actual drugs are working. Again, you don't have good guidance in deciding which drug to use first. A lot of it's going to just be made empirically. You can kind of pull any SSRI out of a hat and say, this is the one we're going to try. But the big things to look at is, one, the history of response. So what did they try previously that did or did not work for them? Look at their concurrent medical illnesses, if there's any kind of interacting factors there. What their presenting symptoms are, the cost of the drugs. Obviously, they cannot afford medications, they're not going to take them. And then you want to look at drug-drug interactions, adverse reaction profile, and then patient preference. So again, what type of meds do they feel like are going to work for them, might influence their compliance as well. So those are all good to factor into what kind of decision on which med you're going to use for that patient. So the antidepressants are typically classified either by their chemical structure, so that's why you hear tricyclic antidepressants, that's based on their chemical structure, or on their presumed mechanism of action. Again, this is not going to be linked back to their direct therapeutic effect, so just because something blocks reuptake of serotonin does not mean that's how it fixes depression, right? Versus something like a beta blocker where you block beta receptors, the heart slows down. That makes sense. These are not going to be so clear cut, but it does help you to determine kind of what their clinical side effects are going to be based on how their mechanism is. So again, therapeutic effects are not linked back to the mechanism, but side effects very frequently are. So again, in order to achieve full therapeutic effect, you want to at least try out these drugs for 2 to 6 weeks, probably longer on the 6-week side, and let them know that adverse effects are going to happen pretty shortly after you start taking therapy. So some of them will get better with time, but those are oftentimes going to be the first thing the patient experiences, the side effects, before they ever start to get better. So again, education is important here. And then when you look at the actual failure rate, it could be anywhere between 20 and 30% of your patients. Some patients may just have pharmacogenetic resistances to treatment. That's a possibility. Or it could be either inadequate drug dosage or actual trial period that they've been on it for. And then also look at your non-compliance issues, right? So the patient comes back and says, I didn't feel any better. You got to find out if they're actually taking it the whole time or not. And that could be a big reason for treatment failure.
Okay, any questions from stuff from last week? Any orthopedic, pain management stuff? Anything at all? So you guys are experts at pain management now. You could fix any kind of boo-boo that comes along, right? Tramadol for everyone. What's one of the problems with tramadol?
Renal function.
Okay, what do you see when you have bad renal function in tramadol?
Decreased GFR.
Well, when you have decreased renal function, you have decreased GFR. But what's the implications with tramadol?
Decrease the effects of respiratory effects and those kinds of things of tramadol?
Potentially, but it's only partial agonist. You don't really see a ton of respiratory depression with tramadol like you would with like a full agonist. Seizures can be a big thing, right? Because remember, it's blocking reuptake of things like norepinephrine, serotonin. So because of those effects as well, you can see the risk for seizures developing with tramadol. So be aware of that one. One of the things that I noticed when I was present for the lab the other day, which actually was pretty interesting. It was fun to get to participate in that. Hopefully I didn't put anyone off too much. But the question of like acute pain management, say a patient who's coming in for acute appendicitis or pancreatitis or something, what is good acute IV pain management options? Dilaudid, yeah, hydromorphone's a great one. They have available IV. What's another one? Morphine. A lot of times if people are allergic to morphine, there's less cross-reactivity with something like hydromorphone. But what's another option you could give that has like no cross-reactivity to morphine allergy? Well, yeah, so Toradol would be a good option, right? That's a good one you can give IV as an NSAID, right? It's not an opioid, but it is opioid sparing, so you could potentially get away with not using an opioid for some more, minor pain cases. What's another good one, though? Phenergan we'll talk about a little bit later, like in the GI section in the antipsychotics, but it's not a pain medication specifically. So fentanyl is another good one, right? So fentanyl we use quite often for patients either like a morphine allergy, or we can use it intranasally if we don't have IV access for them. So those like are your kind of good go-to IV opioids that you can use. So keep that in mind. A lot of the other ones are available only like orally, so like hydrocodone only comes orally, oxycodone only comes orally, like codeine, things like that. But you guys will learn that as you go through practice and kind of figure out what's available for your patients. So anywho, so getting back to our behavioral talks, all the Cheerios get cleaned up?
Yeah.
Awesome. So as far as antidepressant therapy, we mentioned that placebo effect is pretty high here, and so that's why it's so difficult to determine just how effective a lot of our antidepressants actually are in treating depression. So some people will have natural remission of symptoms, say in 6 to 12 months. So but what we do see is that a lot of those patients, even if they were to receive placebo and have positive effects, is they do have recurrence. So that's why a lot of these patients are going to be on therapy for, in some cases indefinitely, especially if they have more recurrent episodes. So we'll see that as far as our antidepressants go, many of them do not differ necessarily in efficacy, but we will see that the adverse side effects are oftentimes what kind of dictate what therapy you're going to use. So things like our tricyclic antidepressants, or TCAs, are going to have a lot more side effects, both at therapeutic doses and also at their overdoses, right? Because we mentioned kind of one of the first things you see when you start someone on an antidepressant is kind of an increase in energy, right? So you don't necessarily fix their depression issues, but now they have more energy. So before, they might have had thoughts of suicide, but they didn't really have the energy to actually act upon those things, right? So now all of a sudden they have more energy, and they say, okay, well now I'm going to go kill myself, right? And so with these overdoses, that can be one of the problems you see kind of early on in therapy. And so you'll see that an overdose with an SSRI is a whole lot different than an overdose with a TCA, right? One's potentially lethal, the other one is pretty safe for the most part. So we'll see some of the differences when we talk about the different classes of meds. So we will see that the meds that have kind of less specific mechanisms of action, or that have effects on multiple receptors or affecting things like enzyme degradation or degradation of monoamines, are going to have more side effects. So those are our older agents. That's where you see things like the monoamine oxidase inhibitors are kind of our first ones we had there. And then as you get to more newer agents, you're going to see they're a lot more selective. So this is where we see like our selective serotonin reuptake inhibitors, our SSRIs, and then we also see some of the newer agents like our SNRIs, which are selective norepinephrine reuptake inhibitors, right? So how do these drugs work? This is a nice complicated slide, but I'll kind of go over it piece by piece. So typically, and this is makes more sense when you kind of take it as one neurotransmitter at a time. So when you're looking at something like serotonin, right, and how serotonin often abbreviated? Yeah, 5-HT, right? So we're going to look at this this bottom serotonergic neuron initially. So what happens normally is you would have release of 5-HT into the synapse, where it can act on lots of different serotonin receptors. We'll find that there's all sorts of ones that work for things like nausea, vomiting, some that work on migraines, but for here, there's lots of varieties, but just know that they are working on the serotonin receptors that are present there on the synapse. And so normally what would happen is that serotonin doesn't necessarily get broken down and degraded right there in the synapse. A lot of it gets recycled, right? So by recycling it through these SERT transporters, they can be put back into a vesicle, and then they can be sent back out into the synapse again, right? It's just more efficient to kind of reuse the neurotransmitters you've already produced rather than make whole new ones after you degrade them. So what are the enzymes that are responsible for degrading a lot of our neurotransmitters like serotonin? We have a whole class of drugs that inhibit this enzyme.
Monoamine oxidase.
Yeah, monoamine oxidase. So monoamine oxidase is really important, and you can see here working to degrade and to cleave serotonin into an inactive product, right? So we'll see some medications that work to block this enzyme's activity, which would work to increase levels of serotonin. We're going to see some drugs that are working here specifically to block this transporter to prevent reuptake of serotonin. All of these things are working to increase serotonin levels within the synapse. Now, is that specifically the mechanism of action for efficacy in depression?
We don't know.
We don't know. That's a very good answer, yeah. We don't really know. We for a long time, we thought that increasing levels of serotonin in the synapse was the thing that fixed depression, but we know that's not really the case, right? Because otherwise, these drugs will work immediately, but they don't. They take like 6 weeks to work. So there's probably some downstream factors that we're not really super aware of at this point. So similar activity is going to be happening here with norepinephrine, otherwise abbreviated as NE. You're going to see that they also will be reuptaken through a net transporter, while some drugs are going to be blocking this. Notice that things like TCAs are not very specific. You're going to see that they're going to be working on lots of different types of receptors. They're going to work both on norepinephrine and serotonin. Things like SSRIs are going to be much more specific, just working for serotonin by itself, right? You're going to see that serotonins are going to work on things like alpha receptors. So if you block alpha receptors, what do you think it's going to happen to, what do you think it's going to cause physiologically?
Vasodilation.
Yeah, vasodilation. So hypotension can be a thing you can see with TCAs. That can be a problem. And you also notice, what do you think these receptors here on the neuron do?
The alpha receptors in there.
Well, not necessarily the alpha receptors, but specifically here, these neurons that are residing on kind of the initial, the initiating neuron, I guess you could say, the ones that's actually releasing the monoamines. What do you think this receptor is doing?
Like a loop receptor, so if there's enough that the tell it you don't need to produce hormone.
Yeah, exactly. So it's an autoreceptor, right? So essentially, when we have high enough levels of things like serotonin and norepinephrine, it kind of feeds back, hits these receptors, and your neurons says, hey, we have enough that's in the synapse here. Let's go ahead and stop releasing anymore, right? So just remember the autoreceptors are also present in our play here, but for our talks on depression, not super important. Do you remember any specific antihypertensives that work on activating autoreceptors? Specifically this alpha-2 autoreceptor?
Like an ace.
Hmm? So remember clonidine. Clonidine is a good one here that will activate alpha-2 receptors, right? Because we said that's a sympatholytic drug that will actually decrease the amount of monoamines that we're releasing. So less norepinephrine, less serotonin, all kinds of different things. And so that way you end up seeing decreases in blood pressure and heart rate because it's sympatholytic. So keep that in mind. Okay, so any questions on this slide? So you kind of get a basic idea of the mechanism, how things are being recycled and being released. You can see where some of our drug targets are going to be working at. Okay, so in general, the mechanisms for these drugs are to enhance either the activities of norepinephrine and serotonin, or one of those specifically on their own, either norepinephrine or serotonin. Like we mentioned, the mechanism of action is not fully understood, but we think that there's probably some changes that happen downstream that are having some positive activity here. So it could be related to things like receptor density, maybe changing, like downregulating some of those receptors, because we know that as we increase levels of those neurotransmitters, you're going to start to downregulate those receptors. Could be changes in their second messengers. You guys remember that from pharmacodynamics? Right, I repress those memories too. But yeah, there's some G proteins that are second messengers that work here. And there could even be some changes in gene transcription, different proteins that are being produced, like this BDNF, or its brain-derived neurotrophic factor. So just be aware of how the drugs are specifically working, because that's going to be informing what their side effects are going to be. But as far as the mechanism, how it works for depression and anxiety, we're not fully sure. So the first group that we had were going to be our monoamine oxidase inhibitors, right? So this is a very old class of drugs. How often do you think these get used clinically? Yeah, not very frequently. So this is more for historical perspective and to give you a good kind of well-rounded idea of how these drugs work and what you can expect from all of these side effects. Basically, what we see is that with a lot of the older agents, we had this drug called ipronizid, which is one of the first monoamine oxidase inhibitors. It was actually an anti-tuberculosis agent. And so what they saw was that they had elevated mood in their patients. They would see that they had some positive effects on their mood. So they said, well, this might be working for other things than just tuberculosis. There's also another drug. You guys ever heard of methylene blue? Probably mentioned it before. It's used to treat things like hemoglobinemia. Interestingly enough, it used to be one of the first, back in the day when malaria was much more of a big issue, quinine was in short supply, quinine being one of the main drugs that we were using in order to treat malaria. And so they found that this drug, methylene blue, was useful for blocking that. And so they started to notice some kind of increased mood in those patients. And they would also use it as a tracer, kind of a dye, for patients who were in mental health institutions. And so essentially, if you were taking this methylene blue, it would come out in your urine, and you'd be able to see whether the patients were actually taking their drugs or not. And so they also saw increased mood in those patients as well. A lot of it was due to this monoamine oxidase inhibition. Okay, so that's where a lot of these initial drugs came from, kind of just serendipity that they found these effects. But since then, we found drugs like phenelzine, isocarboxazid, all these other monoamine oxidase inhibitors. And note here that they are going to be irreversible inhibitors, which means, what do you think about their duration of action? Very long or very short? should be long, which can be problematic. And you're going to see they're going to inhibit both monoamine oxidase A and B. When we talk about Parkinson's, we're going to see that there's one group of drugs that are going to be working strictly on monoamine oxidase B, which will help to limit some of the side effects, but they will have some similarities here. So by blocking these enzymes, you're going to see metabolism of serotonin, norepinephrine, and dopamine being decreased, and that will lead to increased levels of this. And you can also see that the exogenous sources of monoamines, things like tyramine that you take in through your normal diet, can lead to a lot of drug interactions. So again, by increasing levels of serotonin or epinephrine, and now you're increasing, say, exogenous supply of tyramine, which gets converted into things like norepinephrine and serotonin. This is where you're going to see some of these drug interactions that come about from this. You guys think of any tyramine reactions off the top of your head? Beer, some that has high tyramine. What kind of cheese? Kraft singles. No, all right, some aged cheeses.
Hot dogs.
Hot dogs, yeah.
Tofu.
Tofu? I haven't heard of tofu. I wonder if that's in my slider. Like red wine, dark chocolate, so like all the good stuff in life is basically on this tyramine list, unfortunately, which makes sense because, it gets converted in serotonin. Serotonin's a feel-good, kind of neurotransmitter. So a lot of that kind of makes sense from that kind of standpoint. So the main ones you're going to see here is going to be phenelzine, this tranylcypramine, and then selegiline is the one that we're going to use primarily for Parkinson's disease. So we won't talk about that one so much here, but we will when we get to the neurology section a little bit later on in the class. So main adverse effects. So one of the big things you're going to see is postural hypotension. This is very, very common, meaning they're standing up and they're not really able to help regulate their flow of catecholamines. So they are not able to regulate their blood pressure well when they're going from sitting to standing. So that can be a big issue, especially with your older patients, especially those who are at fall risk. You can see some issues there. Other common things you'll see with some of these medications include weight gain and sexual side effects. So this can be anywhere from decreased libido, anorgasmia. You're going to see that a lot of these antidepressants are going to have sexual side effects. So we'll talk about one specifically has the lowest incidence of that. And so keep that in mind. Think about your patient. Make sure you're kind of getting what their take on things are and what's important to them. Because again, if they're having decreased libido, that may be worsening their depression. So kind of take all aspects of it into account. And then the other issues you run into are going to be issues of kind of monoamine overdose, essentially. So by blocking this enzyme, and if you were to increase the exogenous source of these monoamines, you can end up seeing a hypertensive crisis, right? So they can start to have headache, nausea, vomiting, stiff neck, diaphoresis, all these things are just catecholamine excess. This is especially going to be if you have tyramine-containing foods, or if you're going to have medications that would have hypertensive effects, or things that are blocking reuptake of some of these monoamines as well. So this is why you run into big drug interactions with, say, something like a monoamine oxidase inhibitor, like phenelzine, and say something like a tricyclic antidepressant, right? You don't want to mix these medications because they're going to have synergistic effects on those neurotransmitters. You can see CVA and death secondary to this, potentially, and it could even occur after drug discontinuation, because remember, these are irreversible inhibitors, and so it takes about 2 weeks for the brain to start to regenerate those enzymes to get back to kind of normal level, right? So keep that in mind. There's going to be a washout period where you don't want to necessarily stop someone on their phenelzine and then start them on, say, amitriptyline the very next day, because they're going to have some residual effects due to that irreversible inhibition there. Okay. Main way we're going to treat this is just with things like antihypertensives. Clonidine might be a really good option here because that's going to be a sympatholytic and help to decrease release of neurotransmitters. So that could be one option. But really, any antihypertensive is going to work here, right? You guys remember any drugs you could use for that? So you had a patient who's having a hypertensive crisis. They went out to, they were on their phenelzine and they went out to a beer festival, craft beer festival, and then they're coming in, their blood pressure is like 190 over 100. Any drugs you could use to treat that? Labetalol might be a good option. It's a good IV option you can use, right? Because that has some alpha blocking effects and also some beta blocking effects. So that can be good. Anything else you can think of? All last semester, you can go back and review some of the stuff. Yeah, so especially like hypertensive crisis, like enalaprilat or is the IV ACE inhibitor choice you can go with. It works pretty well. You can also use things like hydralazine is a good vasodilator you can use for acute management of hypertension. You could use things like, usually don't use IV calcium channel blockers. Those are usually more your non-dihydropyridine, so it kind of has a little bit too much kind of negative cardiac effect. specifically on the heart. But yeah, there's some good options. You could use things like nitroprusside, nitroglycerin. All these things can be useful as vasodilators to help with that hypertensive issue. So think about that. Remember those medications we can use to help lower the blood pressure if we need to in a pinch. Okay, so the foods we mentioned: wine, beer, aged cheeses, sour cream, yogurt, all the good stuff. MSG. Where do you normally find a lot of MSG? Yeah, Chinese food. Yeah, that can be a big one. So monosodium glutamate. Gives you imagine it's you know.
Foods in general.
I'm sorry.
A lot of salad dressings.
Okay, no, what's
Start reading the labels.
Chips.
And chip, yeah, so you can find it lots of different places. Soy sauce, coffee, sauerkraut, licorice, all these kind of different things where you can find a lot of tyramine. And again, the best way to avoid these interactions, because again, getting someone to fix their diet can be difficult sometimes, just probably don't prescribe these meds. Probably going to be the best thing for them, right? Very rare you'd need someone to actually have to be on one of these. But this will come up again when we talk about the Parkinson's meds, because you'll see the same lesser interaction, but still present with that selegiline. Other medications that can interact with our monoamine oxidase inhibitors by increasing catecholamine release or by working to have increased kind of sympathomimetic effect. Amphetamines can be a big one, so like ADHD medications, as we'll talk about a little bit later on. You can see it with just illicit substance abuse, right? Along with that, what's a common over-the-counter med you can use to make methamphetamine? Sudafed, yeah, so pseudoephedrine is going to be on that list. Certain asthma medications, anything that's kind of pro-sympathomimetic, so like beta-2 agonists, cocaine, decongestants, and a lot of other antidepressants are going to have synergistic effects with these guys. So lots of drug interactions, lots of side effects, so this is why these medications kind of went by the wayside for the most part. So then we have our tricyclic antidepressants, and so these were actually derived from the phenothiazines, which when we talk about our antipsychotics, that's where that group of medications came from. And so these will have, I call the TCAs their mechanism of action they're kind of dirty medications, meaning that they don't have very focused mechanism of action. They affect lots of different receptors, meaning you're going to see lots of different adverse drug reactions associated with this. And so by affecting serotonin and norepinephrine reuptake transporters, they're going to be increasing levels of those in the synapse. They used to be used as first-line therapy. They used to be the kind of go-to antidepressants, but they've kind of been supplanted by the SSRIs for the most part. But you will still see these being used for some other kind of off-label uses. So where do you think you might see like a TCA being used other than depression? You guys know? Or did you cover that in behavioral? Yeah, insomnia. So insomnia can be a big one, right? So sometimes you'll use this for sleep. We'll see that. And then, like I mentioned, neuropathic pain, right? We saw that in the last lecture, if you guys remember that. Or if you've repressed that already, you should probably at least go back to that one. It's still testable. But yeah, so neuropathic pain can be an important source of use for things like amitriptyline. So, right, so those are going to be the big ones. So the available agents we have here, probably I would say the most common ones that I see being used are amitriptyline, doxepin. I see a good amount of imipramine, nortriptyline. Does anyone know a specific indication for imipramine? It might be used for kids. Say at nighttime. Yep, yeah, so nocturnal enuresis, as I say. So for bedwetting, sometimes you'll actually use that, and we'll talk about why that is in just a minute based on the receptor pharmacology. So those are the available TCAs you might actually see being used. If you actually look at the chemical structure, not all of them are strictly a tricyclic antidepressant, but just for ease of categorization here, we're just going to call these all TCAs. So the adverse effects. Big one is going to be the anticholinergic effects, and this can explain why you might use this for bedwetting at night for young children because of the anticholinergic activity. So they're blocking muscarinic receptors, and so this is a good mnemonic to remember for the anticholinergic effects. I'm sure you guys have heard this before, either from me or from someone else. But so mad as a hatter, what does that mean?
Crazy.
Great. All right, so you can see altered mental status early on, like early kind of lower doses. You see some sedation, which is again why you can use these medications for sleep potentially. As you get higher doses, you start to see more excitation, so you can start to see altered mental status. You can start to see hallucinations, seizures are potential. Does anyone know actually where Mad as a Hatter comes from? What actual substance? Yeah, it's actually mercury poisoning from hat filters back in the day. But you know, Alice in Wonderland kind of coined the term, so this is where we use it for this mnemonic. Blind as a bat, what does that mean? In mydriasis, right? So you're blocking muscarinic receptors, you're going to see mydriasis, and they have trouble accommodating, so they often get blurry vision associated with that as well. Hot as the hair? pretty self-explanatory. Hyperthermia, this is going to be a potential risk here. Dry as a bone.
Dehydration.
You want Sjögren's and stuff? Or no, do diabetes, right?
Yeah, so basically by blocking those muscarinic receptors, you see decreased secretions everywhere, right? So you can see dry mouth, there's xerostomia. You can end up seeing urinary retention, why it's good for bedwetting. You can see, you know, even if they're getting hot due to the anticholinergic effects, they oftentimes have dry skin associated with that. So everything is kind of, all the secretions are stopped essentially. And then red as a beet, you see some vasodilation, so you can get some flushing associated with that, and then tachycardia. What do you think these do to bowel sounds? Increased, decreased? Should be decreased, yeah. So you can see some issues there as well, where you can cause slowing of the GI tract. It can be problematic in some cases. So, and then one of the other big things that we're going to see with this as well, that we run into from the tox standpoint, is going to be cardiac conduction delays. So this drug also has the ability to block sodium channels. So this may play, it doesn't really play a role into why they cause seizures specifically. We'll talk about why that is in a minute. But by blocking sodium channels in the heart, you can end up prolonging your QRS interval, and then you can also see increased risk for ventricular arrhythmias that can occur. So very frequently what ends up killing these patients when they overdose on these medications is either seizures or the cardiac conduction abnormalities. So the arrhythmias are going to get them as well. What's kind of interesting is the antidote for someone who's overdosed on tricyclic antidepressants is actually to do serum alkalinization, or essentially you give them sodium bicarbonate to try to raise the pH of the serum above what would be, you know, considered normal for a person. And so one of the big things that we see with that is by giving that big sodium load, you can help to reset those sodium channels. But the way we decide whether or not to do that is based on that QRS interval. So because we know there's kind of a dose-dependent effect there, as the QRS interval gets longer, we can know whether or not we need to treat that patient based on the risk for seizures and dysrhythmias. It's one of the interesting things you can look at on the EKG to determine whether or not you need to treat or not. You will see hypotension from this alpha receptor blockade. And then also you're going to end up seeing sexual dysfunction, weight gain from these, and then we mentioned sedation already. Some of that's due to the anti-muscarinic effect, but here you can also see some antihistamine actions as well that can lead to some sedation. Okay. Another big risk is going to be seizures, because these actually will block GABA. Remember, GABA is a major inhibitory neurotransmitter. This will actually block GABA at very high levels, so you can end up seeing seizures related to that as well. So it can be a big issue. So actually in some of my, so, you know, by the time I got into actual clinical practice, you know, SSRIs had already been kind of well established and were kind of the main thing to treat, you know, depression with. But I remember some of my old bosses at the Poison Center, they were talking about how in the, you know, in the emergency department, there's usually kind of a critical care area where you have your sickest patients, like your cardiac arrest and other things going to. They would oftentimes have about 4 beds set up just for TCA overdoses, like back in the 80s, where people would end up overdosing those medications. They'd end up intubated, usually on a bicarb drip in order to help kind of raise their serum pH. But it was very, very significant number of overdoses that came about from this. So it's very good that we have the SSRIs now, because they're a lot safer medications to use just in general. But so SSRIs, you know, they're selective serotonin reuptake inhibitors. They're blocking reuptake of those, or blocking those SERT transporters to increase levels of serotonin in the synapse. And because they are very specific for this transport, you see a lot less side effects than you would see with the tricyclic antidepressants. So nowadays, these are going to be first-line therapy for major depressive disorder, safer in overdose, and definitely more tolerable in general. So the available agents are going to be citalopram, escitalopram. Do you guys know how those two drugs are related? Yeah, so the escitalopram is one of the enantiomers of citalopram. Citalopram is a racemic mixture. So if you ever need to convert, say, a person from, say, escitalopram over to citalopram, it's a very easy conversion. So imagine, you know, if someone was taking, say, 20 milligrams of escitalopram a day, right? You know, that's only one half of the racemic mixture. What would be their equivalent dose of citalopram? Yeah, 40 milligrams, right? So you just double it. Or you can go the other way as well. If I was giving someone 20 milligrams of citalopram, you want to convert them over to escitalopram, it would just be 10 milligrams, right? So pretty easy conversions you can do with those. You have fluoxetine, which is, you know, as Prozac. Does anyone know what Seraphim is approved for? What indication? It's actually related, depression related to premenstrual disorder. So you can see that. Specifically for that indication. Fluvoxamine, paroxetine, and sertraline. So those are the main ones you're going to run into as far as the SSRI class goes. So these have very low affinity for alpha receptors, histamine receptors, muscarinic receptors. So that means you lose a lot of those side effects you end up seeing with the tricyclic antidepressants. You see less weight gain than you would normally see with TCA. But the most common things you're going to run into include things like GI upset, headache, insomnia, but you still see sexual disturbances. So this can be a big reason for discontinuation of therapy for a lot of people is due to that. It's important that whenever you are taking someone off of these medications that you do not do abrupt discontinuation of therapy with some caveats. So, for instance, if you had someone who was on, say, phenelzine as a monoamine oxidase inhibitor, that's an irreversible inhibitor. So, as we mentioned, the duration of action for that drug is going to be pretty long, right? Especially if you're on it chronically. As you say, you just cut that person off cold turkey one day, those enzymes are still being inhibited, right? So, as time goes on, you're going to have a slow switch over as you produce new enzymes, as the old ones get metabolized. And so, you don't really see a big withdrawal effect here, right? TCAs, you can see somewhat of this. SSRIs, you can definitely see if someone cuts off cold turkey, especially if they're using something that has a shorter half-life, their body's gotten used to having this increased levels of serotonin around. So if you decrease that immediately, they can see withdrawal effects, right? Nothing as severe as you see with, say, like an opioid or someone who's on opioids chronically, but you can see a lot of anxiety, sleep disturbances, increased risk for their depression or their anxiety starting to come back. And so it's really important to make sure you taper that dose slowly, okay? The one drug you can kind of get away with not using that, especially if you're worried about compliance for a patient, is to use fluoxetine or Prozac. The nice thing about this drug is it actually has a active metabolite. So as you break down fluoxetine, you're producing this metabolite that also has SSRI effects. And so it's a very, very long duration of action. So you get a very nice taper of it as someone comes off of that. So that kind of goes both ways, though, because if you wanted to switch someone from fluoxetine over to another SSRI, they're going to have still some of that active drug effect around for a while. So you may need to cut them off of their Prozac and then wait a period of time before you actually start them up on something else. Otherwise, you run the risk of having serotonin toxicity, which we'll talk about in just a little bit. So again, for most patients, you'll see some improvement in their anxiety symptoms. Some people it will get worse, but it's usually the minority. And then the one big thing we worry about as cardiac-wise is going to be specifically with citalopram and escitalopram. It can prolong a QT interval. So if you had a patient who had a pre-existing condition, congenital prolonged QT, or if they had a lot of other medications that prolong QT, this is two meds that you'd probably want to avoid. Okay, none of the other SSRIs really have QT prolongation effects. So you will see that many antidepressants are going to have a black box warning for increased risk of suicidality, and that's kind of what I was alluding to before, where especially if you're looking at children, adolescents, and young adults, in some of these short-term studies, they actually saw that early on in therapy that increased risk of suicidality. Again, you're kind of getting more energy, and you can finally start to act on some of those thoughts you've been having for some time, but just never really acted on before, and so that's kind of the thought there. And so that term, that increased energy, is called akathisia. Have you ever heard of that term before? Right? Where's it normally talked about? Guess what condition do you know? Yeah, antipsychotics, right? So it's kind of just feeling like you're just kind of uncomfortable in your own skin. You just need to do something, need to move around. You just have more energy than you really know what to do with. And so that is one of the thoughts of why people are acting on these suicidal thoughts. And potentially you could see some increased risk for a manic episode in bipolar patients, right? Because we know the bipolar patients, there's kind of real two components to therapy, one for their manic episodes and one for the more depressive episodes. And so if you put a patient on one of these SSRIs, you have a risk for kind of triggering off one of their manic episodes. So next we have the SNRIs, which are going to be our selective norepinephrine reuptake inhibitors. So a little bit different mechanism here. You'll see that we have some non-tricyclic antidepressants that have a lot fewer side effects than you would end up seeing with the TCAs, but they're going to be targeting both serotonin and norepinephrine transporters. Sometimes you'll end up seeing these used more for neuropathic pain, so things like fibromyalgia and other neuropathies. And so the main ones you're going to see available here, probably the most common ones I see in use is going to be venlafaxine, desvenlafaxine. Remember, those are going to be the enantiomer and then the racemic mixture. And then duloxetine or Cymbalta. Those are probably the most common ones. I don't really see milnacipran very often, and this levo milnacipran I've never actually seen used in clinical practice, but it is something you might run into. Right, so the first three are probably the most common ones. So adverse effects from these guys, you probably see a little bit higher incidence of GI disturbances and nausea than the SSRIs for this class. We will still see some sexual dysfunction related to that. And then with venlafaxine, you can actually see, because we're increasing levels of norepinephrine, you can see some increase in pathomimetic effects, so you worry about hypertension for some patients. And then with duloxetine, you get kind of a smattering, and maybe have some anticholinergic effects with this one, more so than you would see with like a venlafaxine, but see nausea, dry mouth, constipation, they can go along with that. Okay, so the next group is going to be kind of our mixed serotonergic agents. These are going to have a little bit more of a grab bag set of mechanisms. First one we'll see is going to be trazodone and nefazodone. These actually work by blocking reuptake of serotonin receptor, or blocking reuptake of serotonin, and it actually works as a 5-HT2 antagonist. So it actually blocks the effects of serotonin at these specific receptors. Other cases you're going to be, or other mechanisms you're going to see with these drugs, including with trazodone, is that it blocks alpha-1 receptors. So you're more at risk to see hypotension with this drug, and dizziness associated with that, especially like postural hypotension can be a big issue. You typically don't see a lot of nefazodone being used due to cases of some liver failure occurring. So I really see a lot more trazodone being recommended than nefazodone. They all have this newer one, vilazodone. Not a ton of new information out there about that one, but it's probably newer in this class. Other adverse effects: hypotension, dizziness, sedation, like we already mentioned. Oftentimes these get prescribed as sleep aids, especially for patients who, or for people who cannot prescribe controlled substances. So I would see this a lot previously with a lot of mid-level practitioners who would prescribe trazodone for sleep because they could not prescribe things like your benzodiazepines or your benzodiazepine-like drugs for sleep. So this is a very common use for a lot of these. But fortunately, that will not be a problem for you guys when you get out, right? Yeah, you can prescribe all the stuff you want. The other big adverse effect, this is a unique thing with trazodone, is it causes priapism. This is directly related to its alpha-1 blocking effects, and so we can see this either as kind of a one-off side effect from therapeutic use, or you can see this as an overdose as well. So I've run across a few cases of that. So it's a kind of a unique thing you see with that one in particular. Okay. And then there's bupropion or Wellbutrin. Does anyone know where you might see bupropion being used other than for depression? Yeah, smoking cessation. Zyban is the brand name you'll see used for that. Anywhere else you might see being used?
Migraine control.
Migraine control, potentially. Yeah, weight loss. So that's actually one of the newer cases where, based on the mechanism here, so this one's a little bit different because this actually works to block reuptake of norepinephrine and dopamine. So this is kind of the unique niche that this one falls into. And if you imagine, by increasing levels of dopamine, especially along that reward center pathway, you kind of help to regulate things like, binge eating, things like that. Because again, when you go out and eat a bunch of really good food, you're triggering that reward pathway. So this is thought to help kind of regulate that and help lead to some weight loss. And so there's actually some products out there that combine something like bupropion with naltrexone, which is a opioid antagonist that we did not talk about because it doesn't get used a lot clinically, but here it's working to kind of help block some of those kind of compensatory mechanisms that occur by regulating that dopamine by working with some of the natural endorphins that your body produces. But neither here nor there, but just be aware you might see it being used for other cases. And so this one is nice because it has a little bit different side effect profile than you would see with some of the other agents. I think I'll talk about it in the next slide. Yeah. So you will certainly see some similar side effects to like your SSRIs, so nausea, vomiting, things like that. But because we're increasing levels of norepinephrine and dopamine and not really affecting serotonin, you see less sexual dysfunction than the SSRIs. So if you have someone who's experiencing sexual dysfunction or is particularly concerned about that developing during use of these meds, bupropion is the one to go with, right? The drawback is that you have increased risk for seizures and arrhythmias. A lot of this is dose related, so you can run into this, especially with overdoses. I've had patients that were awake and talking to me that had overdosed on bupropion. We sent them up in the elevator to go to the ICU for observation and had cardiac arrest in the elevator, right? So they can go very quickly with bupropion overdoses. So just be aware of that if you ever see it. It's a very serious overdose you don't want to take lightly, even though the patient doesn't look that bad to you. Okay, some other kind of one-off medications. We have Mirtazapine or Remeron. So this one is going to be an antagonist at presynaptic alpha-2 autoreceptors. We kind of mentioned that something like clonidine is going to be an agonist at these alpha-2 receptors. This is going to be an antagonist. So we're going to increase release of those catecholamines. So both norepinephrine and norepinephrine get increased, serotonin and norepinephrine get increased release. You also see it working to antagonize some serotonin receptors, and will also block histamine as well. So a lot of the adverse effects are related to some of those effects. You see constipation, dry mouth, weight gain, but this is sometimes used for patients who are refractory to other therapies. It's kind of like a second or third line agent you might try out. Okay, bortioxetine. This is a newer agent that came about from just doing yearly updates and whatnot. But this one is acting as an SSRI and also acts as a serotonin agonist, partial agonist and antagonist. And it really just depends on which type of serotonin receptor you're looking at. So I'm not going to get into the specifics on that. Just know that it has mixed serotonin activity depending on the type of receptor that's working at. Most common adverse drug reactions you're going to see include diarrhea, nausea, and then the sexual dysfunction you can run into. And then another thing you might run into is the fact that this is metabolized by CYP2D6. So people who are poor metabolizers may actually accumulate drug and have more risk for toxicity. Okay, so I'm sure you guys have heard of serotonin syndrome before, right? What is serotonin syndrome?
Too much serotonin.
Too much serotonin. That's a very succinct way to put it. So this is going to be occurring when you have either one medication that has very significant effects to increase levels of serotonin, especially if it's dose related and say overdose, or if you were to have multiple medications that are interacting here to increase levels of serotonin. So major effects you're going to see, and oftentimes this is more of a diagnosis of exclusion. So you kind of rule out a lot of other things before you can say, yes, this is serotonin syndrome. I've only seen kind of true blue cases maybe 2 or 3 times in my time in the ER and the ICUs. So it's not as common as you might think, but certainly lesser degrees of this can be experienced by patients, and we would just call this serotonin toxicity, right? So some of the things you're going to see include things like altered mental status. You can see hyperthermia, so that can be a big one. You will see autonomic instability, so they could be hypertensive, tachycardic, they could be hypotensive, bradycardic. It kind of just depends on the patient. And then you also see this increased muscle tone. So you guys have heard of neuroleptic malignant syndrome? What type of drugs do you see that with? The antipsychotics. And so with that one, they describe as lead pipe rigidity, or basically the patient can just not relax their muscles, right? This is not quite so severe with the rigidity, but you can see a lot of like lower limb clonus, especially. So you can have this like kind of inducible myoclonus that you can see in your patients. So that's a more common thing you'll see with serotonergic toxicity versus neuroleptic malignant syndrome. So again, so if you were to have, say, like a monoamine oxidase inhibitor on board, and you included, say you had like a whole lot of tyramine intake, that could trigger this. If you had, say, an SSRI plus, which in a antibiotic can have some MAOI activity. Not macrolides. Linazolid's a big one, right? So that's a good one to remember because that can interact with a lot of these antidepressants. So an SSRI plus linazolid could potentially do this. Did I ever mention the person who's having the parathyroidectomy who got methylene blue? So that was a case where parathyroidectomies will use methylene blue because it helps, it actually accumulates there. And so there was a case where someone was on an antidepressant, they received methylene blue in order to help stain that, and did not realize that methylene blue also had MAOI activity. And so they ended up seeing serotonin syndrome in the post-operative setting, which is pretty significant. So just be aware, usually it's going to be with mixed medications, or if you have that tyramine reaction with your monoamine oxidase inhibitors. So again, some other signs and symptoms you can run into. In very severe cases, you can even see things like rhabdomyolysis and secondary renal dysfunction due to precipitation of the myoglobin in the kidneys. And so the main thing we're going to do is just really supportive care. So really just want to hydrate well, cool them down if there are they're hyperthermic. So you can use things like evaporative cooling, where you can kind of like wet them down and put fans on them, or you can do ice packs in the axilla or the groin, things like that. And then the actual antidote, which probably doesn't get all that often, is going to be cyproheptadine. And then cyproheptadine is actually a first-generation antihistamine that has some serotonin blocking effects. So the idea here is if you have too much serotonin activity, you can block it with cyproheptadine. Periactin is the brand name for that, and will sometimes be used for appetite stimulation as well. So that's probably the other place you might see cyproheptadine being used frequently. Okay, so looking at the kinetics of our antidepressants, so it's important to consider especially looking at other medications the patient might be on to know which kind of interactions you can expect to see. So agents who have longer half-lives or have active metabolites, so the big one here is going to be fluoxetine, are going to be great for patients with compliance issues. Because even if they stop taking it, they're not really cutting themselves off cold turkey because they're going to have drug effect around for quite some time, even after they stop taking it. So you may not need to taper as long when you're considering switching them off of that drug to something else. But if you added something on new right after, say, switching them off of fluoxetine, you can run into issues of toxicity because they still have a lot of drug activity around. You will see that with a lot of these drugs that chronic therapy leads to tissue accumulation, just like with lots of other things. So the actual therapeutic effects may last a little bit longer than you would see based just on their half-lives themselves, right? And so we will see that many of the drugs are metabolized to the liver, and so especially with like patients with poor hepatic function, cirrhosis, things like that, you're going to see increased half-lives for a lot of these drugs. We do not use therapeutic drug monitoring for a lot of these because even if we had, say, a fluoxetine level or citalopram level, it doesn't really correlate to anything clinically because we don't really know what levels, are seen to be effective for treating depression. Again, we don't even know if the drugs are actually being all that effective considered in the placebo effect here. But really, you're just titrating the dose based on their actual symptomatic response. So they have some improvement after 6 weeks, try bumping up the dose, right? They have no activity after 6 weeks, maybe try switching over to something else. But it's important they give it that full 6 weeks to really assess for full efficacy, because otherwise if they discontinue early, you'll have no idea if the drug actually worked or not. Okay, so a lot of the newer agents, you're going to see things like venlafaxine, duloxetine, bupropion have fewer pharmacokinetic interactions. But you will see that the SSRIs and some of the newer agents have variable effects on CYP enzyme inhibition. So be aware of that. Make sure you're checking out your drug interaction reports before adding on a new medication to their profile. A lot of the TCAs are metabolized extensively through CYP enzymes. So again, just look up these interactions prior to prescribing. A lot of these have to do with like CYP2D6 interactions. CYP2D6 is really important both for heart medications and for head medications. So it's kind of the way I remember that one. Just be aware. Make sure you look up those interactions beforehand. With TCAs, especially due to the side effects, which those can be apparent even with the first dose as opposed to what their therapeutic effects will when they manifest. Start at low dose and titrate up gently to see what the patient can tolerate. And you may also run into some protein binding interactions with some of the TCAs. Just be aware of that. If there's anything that will kick those drugs off the receptor, make them more prone to have a higher pharmacologic fraction, and can lead to some toxicity as well. Okay. And again, any drug that will be affecting serotonin can contribute to the serotonergic toxicity. So you can see linazolid's a big one, methylene blue, even our triptans, which we will talk about in the neurology section when we talk about migraines and headaches. These are going to be 5-HT receptor agonists. So they can have kind of pro-serotonergic effects. So you can see some interactions there. And oftentimes, in order to use these drugs effectively, the ideal way to do it would be to have antidepressant cessation, where you'd actually titrate off their dose and have a washout period. But clinically, you don't see that this is super feasible to do in a lot of cases. So for instance, if you have a very significant VRE infection or vancomycin resistant enterococcus, I can't give them 2 weeks to wash out of their antidepressant before putting them on linazolid. You just have to put them on it and monitor for those effects. Again, we will see that the QT interval prolongation is specific to citalopram and escitalopram, so be aware of that when you're adding it on to things like antipsychotics. A lot of those can prolong QT intervals, and if they're on antiarrhythmics, be aware of that as well. And then you'll see some synergistic sedative effects, especially with the TCAs, when you're adding that on with things like alcohol or benzodiazepines. So they need to be warned to not mix and match their medications, or at least be aware of that for the first dose. Okay, and you guys, I'm sure you've heard of St. John's wort before. It's a very large wort. It's very difficult to treat. So what is St. John's wort? It's a plant? It's an herbal supplement. That's probably the more important thing, right? So it's a plant that gets turned into an herbal supplement that actually has some efficacy for treating depression, right? So the active compounds is hypericin, which is thought to be a monoamine oxidase inhibitor, and also can block some of the reuptake of monoamines. And so this is one of those few herbal supplements that probably has more evidence to support its use than some of the other ones. Don't want to cast any shade against herbal supplements if people are really into those. But you can see a lot of significant adverse effects from this and potential drug interactions, especially if you're not aware that they're taking this when you are prescribing new antidepressants, right? Same risk for serotonergic toxicity you would see with any other drug combination. So you really need to make sure that they are not taking anything else when you're prescribing your antidepressants that could be interacting. Big thing you run into as well is that this can be a CYP3A4 and P-glycoprotein inducer. That means it can actually decrease the levels of many medications that are metabolized through CYP3A4. So like your statins, a lot of your some of your calcium channel blockers can all be affected by this. So just be aware, make sure you're asking the right questions, make sure you're capturing all of those herbal supplements that may be taking, and definitely avoid mixing with other serotonergic medications. If they want to take this and trial it out, totally fine, but they just don't want to be they need to be forthright with it and make sure you're not having these interactions at play. Okay, so other special populations, oftentimes depression is overlooked in the elderly population, especially when they get older and older. They have increased risk of suicidality, especially over 65 years of age. Make sure you're looking at those PK and PD interactions there, because again, if their liver function or renal function is starting to decrease, that could lead to some interactions there. And they just have less physiologic reserve, so they're a higher risk for a lot of those adverse effects. So especially like TCAs and things like that, the postural hypotension can get pretty severe.
Going back to the St. John's Wort for just a second.
Yeah.
Is there a washout period if you want to put them on these meds because their St. John's Wort is apparently not working?
Mm-hmm.
Is there some sort of washout period for St. John's Wort before you start them on SSRIs or any of these others? Yeah, 2
weeks is probably safe if they've been taking it pretty consistently, and they're going to switch off that kind of cold turkey. Like 2 weeks is probably good for a lot of these meds. It could be extended if they were. Because like fluoxetine having such a long duration of action, like that one probably needs a little bit longer. It's kind of one of those things where you decrease their dose and then maybe 2 weeks in start to titrate up on a new one. But generally 2 weeks is pretty good, right? Good question. With pediatrics, this is actually probably a lot more prevalent than one once thought, and the medications here especially have not been super well studied, right? Really only fluoxetine has indication for kids less than 18 years of age, so that's probably a good go-to one, but certainly most of them are going to have very similar efficacy, just we don't have enough evidence behind that. But the big thing here is the black box warning for increased risk of suicidality, so be aware of that. Be sure to monitor for that. Let parents know what to look for, things like that, because it is well known to occur. And again, you don't want to be on the wrong side of litigation if you did not actually appropriately warn against looking out for those signs and symptoms. Okay, pregnant and lactating patients. So again, we know that postpartum depression can be a big deal. We talked about this a little bit in the OB-GYN section. Basically, it's a risk versus benefit analysis, right? So again, if the mother has very severe depression, it may be worthwhile treating them throughout the pregnancy, especially in the post-birth phase, especially when the postpartum blues is more likely to rear its ugly head. So just be aware of that. Probably sertraline, I think it probably has the most recommendations currently with a lot of gynecologists, so, but it could be practitioner dependent. Just be aware that the babies can have withdrawal effects if the mom was on SSRIs throughout the pregnancy. So again, you can't see those withdrawal effects in the fetus. Again, you just treat supportively. You're not necessarily going to restart them on an SRI that young. So in general, when you're starting someone out for therapy for depression, generally start out with an SSRI or a newer agent. So certainly something like venlafaxine or bupropion could be reasonable. SSRIs are usually cheaper, pretty standard therapy to go with. TCAs are not going to be preferred just due to their adverse effects. And then MAOIs are typically for treatment-resistant depression. They kind of failed many other therapies that might be something you go to kind of last line. If they have treatment failure, certainly one of the big things to do is to assess for compliance. Make sure they're actually having the right duration of therapy. Make sure they've given it 6 weeks. They've been taking it consistently. Make sure the dosing is appropriate. And so, you may be able to switch to different agents within the same class. Just because you fail paroxetine doesn't mean that fluoxetine will not work. But make sure there is that adequate period. So usually about 2 weeks or so before you want to start titrating up on the next dose. And keep in mind, you may need to add on some additional therapy. So for some patients, lithium can be a useful medication. Where do you normally see lithium being used? Yeah, bipolar disorder, so that's a common one. And then sometimes even atypical or second-generation antipsychotics get used. So things like aripiprazole or Abilify are starting to get indications for kind of adjuvant treatment for major depression. So it can be added on for patients who are not being well maintained just on like an SSRI by itself. So you might start to see some increased use of these atypical antipsychotics for depression specifically. So any questions on depression? You guys are all sufficiently depressed? You can tell. Okay. So we'll do a 10-minute break, come back, and we'll start up on the antipsychotics. All right, any questions on the depression meds? So a good question. So someone said, well, aren't the SSRIs and the SNRIs on the Beers list? And what's the Beers list?
Every drug.
It's when you go to the pub and it's what they have the craft section now.
65-year-old.
Yeah, so it's medications you should be wary of using in patients who are elderly. And so, I don't make the definitions, unfortunately. Essentially, you know, there will be some consideration for drug classes where you can say, like, for instance, the benzodiazepines. When we talk about anxiety, we'll talk about those meds. And so you can see where some of them, based on their kinetics, are going to be better for elderly patients than others. So, for instance, some are going to be better for patients who have liver dysfunction or kidney dysfunction. So you should use those for elderly patients versus other ones that have, like, say, extensive hepatic metabolism. In general, though, when dealing with elderly patients and depression, typically your SSRIs and SNRIs have less side effects than you see with something like a TCA. It's more like just a kind of a cautionary, like, hey, just be aware of this. Be aware they're more prone for side effects than, say, 20-year-old patient you're treating for depression. But you can still use them, right? So just be wary of that. Be aware that they're more at risk for things like the orthostatic hypotension, especially with some of the ones that have a little less specific receptor pharmacology, So just be aware of that. Does that make sense? It's all gray. Medicine's more art than science in a lot of cases, so just be aware of that. Okay, so moving on to bipolar disorder. So we talked about the depression. Now we're going to go a little manic here. We're going to get some high energy. Right? Clean our houses really. I'm just kidding. My house is covered in Cheerios and milk and all kinds of other gross stuff. So fortunately, the wife's at home today, so hopefully we'll see. I watched the baby all day yesterday. So she came home and she's like, "What happened here?" And I was like, "I don't know. Like, just take her, please." Okay. So speaking of bipolar, a 7-month-old frequently is. But anyway, so we know this is going to be a chronic and usually not a severe, but a severe cyclic mood disorder. So we know there's going to be kind of fluctuations in mood, their energy, and their behavior. This is different than, say, like a unipolar depression because we're including usually a manic, hypomanic, or some sort of mixed episode phase in there, right? And so very frequently this is a lifelong illness, and so it's important that we include both pharmacologic and non-pharmacologic therapy. So we don't know a lot about the pathophysiology. It could be some developmental factors, some genetic factors, all sorts of different things that be playing a role in here, but we don't really have a good unified pathophysiology for why someone becomes bipolar. But some people think it might be due to altered synaptic and circuit functioning rather than a specific issue with the neurotransmitters. So maybe we can focus on some meds that will focus more on the way that the actual circuits are functioning rather than just dealing with, say, increasing levels of serotonin. So we know how they present in a lot of cases. So some patients will be have different bipolar types. I'm not really going to get too much in the specifics here, but just be aware that there's different subtypes. And so where and how you initiate therapy can change based on that, right? So for instance, if they have a history of bipolar disorder, but they're not currently having a manic episode, you may choose different therapy than if they were to be coming in, having an acute manic episode and have to deal with that first, and then also look at the depression later. So we'll see how that kind of changes as we move on. So, remember that there's lots of other reasons that someone could appear to be manic or appear to have bipolar disorder. So certainly lots of CNS disorders. So if they have previous stroke or tumor, for all causes. Certainly infections can be a definite reason for acute altered mental status changes. You see issues with electrolyte abnormalities. Another big one could be alcohol intoxication or withdrawal. Certainly someone who's alcohol intoxicated could appear depressed. And then if they're a chronic alcoholic and you remove that, withdrawal effects can appear to be manic. It can be very severe kind of hyperexcitation. Certainly steroids can cause changes in mental status. So it's a big one to warn patients about. Hey, you may have some changes in mood or aggression on steroids, so think about that. And then hallucinogens can be another big one, right? So you classically think of someone who's coming in on phencyclidine or PCP, angel dust. They are coming in, they are fighting people, they have gorilla strength, and are usually having to be hogtied and put down propofol or something just to deal with them. So lots of things can kind of mimic this bipolar disorder. So our goals here are to help to eliminate current symptoms, hopefully with complete remission, try to prevent further recurrence of symptoms if we can, and try to help them get back to normal psychological function or psychosocial functioning. Adherence is going to be a huge issue with this, because if you might imagine, someone who is on their manic phase, do they necessarily feel bad? They don't, right? So do they think they need medications? Sometimes they don't, and so sometimes compliance is a huge issue for them. We also want to try to eliminate any kind of contributing factors. So if they're on other stimulants or alcohol, this can be a big issue for a lot of them. And then avoid any other stressors or substances that may precipitate acute episodes. So therapy is going to be individualized for everyone, so not everyone's going to respond equally well to all the therapies here, especially when frequency of episodes and severity can vary pretty widely between patients. And again, we're going to be targeting both pharmacologic and non-pharmacologic therapies. So basically, patients who, especially with recurrent episodes, should remain on some sort of mood stabilizer for their lifetime. Again, the idea is to prevent that recurrence of kind of vacillating between either end of the spectrum there by using these mood stabilizers, kind of keep them in the middle, hopefully, and kind of keep them there as long as we can, unless they have some sort of trigger or something like that kind of pushes them in one direction or the other. And then we'll see that certain medications can be added on for acute symptoms. So if they're having an acute manic episode where they either are, say, like a harm to themselves or others, there's certain medications we can give in the short term to help kind of knock them down and kind of get them back to their baseline. So as far as non-pharmacologic therapy goes, obviously things like making sure they have good stress reduction, exercise, sleep, nutrition are all helpful. Supportive counseling can be big here as well. But the main thing we're going to be focusing on are going to be the drugs. We all like drugs, right? I'm just kidding. Don't do drugs. So the first one, probably the oldest one that we use for bipolar disorder is going to be lithium. Anyone know that used to be able to get lithium in their 7-Up? It's the original lithiated soda. Just like cocaine used to come in Coca-Cola, you used to be able to get lithium in 7-Up. So this is first used back in like 1949. So it's a very old drug as a treatment for mania, and we still really don't know why it works for that. Some people think it modulates gene expression, and anytime you hear something modulate something, they oftentimes just don't know what it does. They're just speculating. Also thought to have some neuroprotective effects as well. But the big things we do know are the kinetics of how it's handled within the body. And this is really important when we talk about side effects, when we talk about drug interactions as well, because too high lithium levels can be very detrimental for your patients. We want to avoid that at all costs. So lithium itself, so if you looked at lithium on the periodic table, so if anyone can go back and visualize that in their head, if everyone memorized it, right? Okay. Where does lithium kind of sit at on the table?
Between hydrogen and sodium.
Yeah, kind of on the left side, underneath. Right around sodium, right? So that's the important thing, is it lives near sodium. The important thing about that is that your body handles lithium just like it does sodium, okay? So if your body wants to get rid of sodium, it also wants to get rid of lithium. If your body wants to hold on to sodium, it wants to hold on to lithium, right? The kidneys can't tell the difference between the two. So that's going to be important when we talk about our interactions, when we talk about how the pharmacokinetics of the drug works. So keep that in mind. So it's well absorbed, just like sodium would be. It gets distributed throughout the body. There's no protein binding associated with it, just like any other electrolyte you would see. And it does not get metabolized. It just gets excreted directly from the kidney. So there's no hepatic issues here, but it will be subject to all the same rules that sodium has. So this can still be considered first line for patients who need therapy for mood stabilization. Efficacy can be delayed. So again, this is another big issue for compliance. If they don't feel like they're getting any better in the initial phase, they may discontinue therapy prematurely. But the big thing here is it's been shown that it can help to prevent manic episodes and then also reduce that suicide risk. Again, a lot of those patients, especially if they are severely depressed and they get in their manic episodes, they can start to act on a lot of these suicidal thoughts they may have been thinking about. So if you can prevent that, hopefully you can prevent them from acting on those thoughts. So the other big thing here is that we will frequently do therapeutic drug monitoring. Do you guys remember TDM? Right? Remember any drugs we would do TDM with? Vancomycin's a good one. Tegretol, carbamazepine, right? So we'll talk about that in just a little bit. Yeah, so remember, we're using blood levels to help us determine what their kind of steady state serum level is, so we can adjust our doses based on that, right? And so this is one of the few drugs we actually have good therapeutic levels on. We know if we go above this, at risk for toxicity, and if we're below this, they're at risk for developing, a manic episode. So I'm probably not going to ask you guys specific levels on a test. If I do, I will put the reference range on there. Okay, but I may give you a patient who say, patient comes in, with a level of say 0.3, and I'll say the normal reference range is 0.5 to 1.2. They haven't had, an episode of mania in the past, year. What do you want to do with their level, right? So that might be to increase their dose, decrease it, do nothing, stop the med altogether and give them something else. So remember, we might ask questions like that. Remember, never treat the number, treat the patient, right? So the patient's doing well, even though the number may be slightly out of range, you don't have to go change their dose, okay? Likewise, if the patient is having significant side effects and the level's in the normal range, that's not normal for them. So you may need to adjust their dose based on that, even though they're within the reference range. Okay, so just be aware of that. Those are kind of questions you may get asked on the test.
Is there too high? Like if they're fine and they're sitting at 2?
That, I would feel less comfortable with that, just because of the fact that they're going to be more prone to, you never know when that tipping point is going to be for them, right? So you never know, like if they get dehydrated and all of a sudden they start to retain more lithium, that may tip them over into having pretty significant CNS effects, right? So that would be pretty high. But if it's like 1.3, 1.4, probably okay, right? Especially if they're not having any side effects, they look good. That might be one of those ones where I'd probably leave it alone. 2, I'd probably be like, let's see if we can back this down at all, because that's starting to get into scary territory. So abrupt discontinuation of lithium is no good. You want to have nice tapers on this one because we can see remission. And you can also combine with other mood stabilizers. So, as we saw with the depression meds, you never want to add on, multiple drugs that are affecting serotonin or multiple ones that are, affecting norepinephrine, because you run the risk of having some issues here. But because lithium is working differently than you see a lot of other mood stabilizers work, you can have some combined therapy there, but you will see increased risk for side effects. So what are those adverse effects? So a lot of people with lithium experience side effects, but for a good long time, this is the only drug we really had to treat mania. So a lot of people just had to deal with it for a lot of cases. But you normally are going to see that the effects are dose related, right? So as your levels start to climb up higher, that's when you're more likely to see the side effects. And it may not peak for several hours, usually 1 to 2 hours post the dose, as when you start to see the kind of peak of side effects. So biggest one, you're going to see GI distress. You can also see some osmotic diarrhea. That makes sense because you're adding on, more ions into the GI tract, which can draw water in. So you can see some diarrhea from that. And then you can also see some issues with muscle weakness and lethargy, especially as your levels start to get higher. Also, one of the telltale signs of too high a lithium level is going to be tremor. So you see kind of a fine tremor in their hands. That's a good way to tell whether or not their levels are going to be too high or not. And then also you can see some issues with polydipsia and nocturia. Again, that makes sense because if you start to, say if your serum sodium level is already high and you start to increase the number of ions that look like sodium, that can trigger your body to want to start to dilute that out some and start to increase water intake. So that might be something you see with this drug as well. So we mentioned the fine hand tremor, especially with chronic use. This can be limited by using more long-acting formulations. So very frequently, patients are not taking immediate release lithium, but they're taking an extended release formulation that helps to deal with this. You don't get as high at peak levels, thus you don't really see as many of those effects related to that. And possibly can be prevented with beta blockers as well, but usually you don't want to add on a beta blocker unless it's very severe tremor and they have to remain on lithium. Usually that would be a good indication to go switch over to something else. One of the other issues you run into is nephrogenic diabetes insipidus. So what is this nephrogenic diabetes insipidus?
Pee all the time.
Yeah, that's a good succinct way to use it. Pee all the time, right? So you're just dumping tons and tons of water through the kidneys, and so this is one of the drugs that, especially when we talk about in the renal section, this will come up as drug-induced causes of nephrogenic diabetes insipidus. So frequently this can be treated with loop or thiazide diuretics, but we'll see this is an important drug interaction with lithium as well. So again, if your patient is just like, hey, I'm just peeing all the time, I can't stop, that could be a big sign that you may want to stop therapy or at least switch them over to something else. Also see some nephrotoxicity, and then you could actually end up having hypothyroidism due to lithium interfering with the synthesis of thyroid hormones. That can be another potential issue. And again, some of those patients may have thyroid disorders already, so it could be interfering with that.
How does the treatment of nephrogenic diabetes insipidus, where they're already peeing like crazy, how does treatment with a diuretic change that?
It's a really good question. How does that work? A lot of it has to do, the issue is that they are not regulating their sodium very well within the kidneys. And so by giving something that helps to reset that a little bit, you can try to kind of normalize the kidneys out, right? I'll get more into detail on that when we talk about it in the renal section. That's as far as I want to get without getting you guys all backwards on stuff. So
Okay.
we'll leave it at that. But yes, it is counterintuitive to say the least. If you're peeing too much, let me give you something to make you pee more, right? Don't do that. Okay. So some of the chronic effects you can see some cardiac effects as well. As you notice here, bradycardia, AV block are possibilities. You can also see some issues of acne and some other dermatologic effects that can pop up from this. Weight gain, and then especially with more high levels, you can start to see slurred speech and ataxia that can develop. And then an overdose, we can run into issues of either acute overdoses. So say someone had never been on the med before and they are taking large doses, say if like a kid got into it. It's going to differ a lot than chronic overdoses. The thing with lithium is that it takes time to cross the blood-brain barrier, right? Because a small ion, you know, it's permanently charged, right? Those don't like to cross the blood-brain barrier super easily, right? It takes time. So initially, if you have an acute overdose, you see a lot of GI effects, you see a lot of vomiting, diarrhea, but a lot of that has not had a chance to cross into the brain yet. But when you have chronic overdoses, especially if you have, like, say, an acute on chronic overdose, where say someone accidentally took extra doses, they've been on it chronically, or say they have a big drug interaction that's raising up their levels, they already have a pretty high brain burden of lithium, and so they're more likely to see some big issues, especially seizures can be a big one. So that's one of the big things we worry about. And dysrhythmias can occur as well. So this can be a very dangerous, especially with chronic patients, especially if they had a level of 2. I'd be more concerned about them because I know that the level at the brain is also 2, which is too high, and they're more at risk for developing the neurologic complications, right? So just keep that in mind. So, sodium restriction, dehydration, anything that's leading to decreased fluid status in the patient can all lead to drug accumulation, right? So, anytime your body's trying to hold on to more sodium, it's trying to hold on to more lithium too, so it's going to cause your levels to go up. You'll also see that other drugs can lead to lithium accumulation. This is a very common reason for a patient to have a super therapeutic level and to have kind of those chronic side effects pop up. A lot of it can be related to thiazide diuretics, NSAIDs, ACE inhibitors, anything affecting salt retention can affect this as well, right? So if you give a thiazide diuretic, you start to increase salt and water release from the kidneys. The brain says, hey, I want to hold on to more salt and water, so it's going to start releasing antidiuretic hormone. That can lead to lithium accumulation, right? Same thing, anything affecting renal blood flow, like ACE inhibitors or NSAIDs, by decreasing that, you're increasing the amount of lithium that is not being excreted in the kidneys. So again, all of that can lead to high levels, right? So very frequently, I did not run into patients who were overdosing on lithium necessarily, but they had started up new medications that were interfering, and that's what led them to come into the hospital with a seizure, right? So say they got started on a new ACE inhibitor, and then they started taking NSAID for headache, and all of a sudden their level is 3.5, and they're coming in seizing, right? Those are kind of the issues you run into. Also note there's no real CYP interactions here because the drug does not get metabolized. It's all really going to be renally mediated stuff. So we said for a while that lithium is all we had. It's a very old drug, but now we have some other agents that are probably also old as well, but not quite as old, but are usually used for things like for epilepsy, right? So we use anticonvulsants very frequently as mood stabilizers. So we'll talk more about these in the neurology section, but we'll kind of touch on them briefly here. First one, and this is probably your big go-to for most of your manic patients, is going to be valproic acid. You may see this being called many different brand names, Depakote, Depakon, Depakine, valproic acid derivatives. You see lots of different names for it. Just be aware that they're all kind of different names for the same thing. A lot of them are different release characteristics of the dosage forms, whether it's extended release, immediate release, whatever it happens to be. But even though it got its original use as an organic solvent, we realized it had properties as an anticonvulsant. So, this is originally used for seizures, but nowadays it can be used as well as a mood stabilizer for most of these patients. This is probably the most prescribed one in the U.S., just due to the side effect profile being so much better than you see with something like lithium. So it's good for both acute manic episodes, and it's good for chronic therapy as well. So you could use it for potentially either. And the mechanism, well, we don't know the full mechanism here. It is thought to increase or at least mimic the effects of GABA as an inhibitory neurotransmitter at postsynaptic receptor sites. Kind of makes sense if your patient is hyperactive and they're manic, kind of increasing the activity of GABA as an inhibitory neurotransmitter can kind of slow things down and hopefully deal with that. So that's kind of the thought there. Again, you may see some synergistic action, so it's possible you may see a patient on valproic acid plus something like carbamazepine or plus something like lithium, but you're increasing your risk for adverse effects as well. So what common adverse effects do you see with valproic acid? Usually some GI distress. Also you can see some fine hand tremor, and sedation is probably going to be one of the biggest ones, especially when you start them off on dosing. They'll kind of get used to the sedative effects over time. This could also be a sign if their levels are kind of out of whack as well. Also see some ataxia, lethargy associated with that. The big things you want to be concerned about, though, are going to be the hepatotoxicity. You worry about that with your patients, so that's one thing you'd want to monitor for is look at their LFTs over time. And also you can see this hyperammonemia. So this is a frequent thing that a lot of people don't check when someone comes in with altered mental status who's on valproic acid. So say, for instance, I had a really good case at Nemours several years ago. We had a patient who was coming in. He was on valproic acid for his bipolar disorder, and he was found at school to be acting just completely odd, right? So he's just slurring his speech and his ataxia. They're like, is he drunk? Is he doing drugs? Like, what the heck's going on here? And so sure enough, comes back, and we end up doing a blood level. Or, he came back negative for ethanol, was denying anything else, but dude was just acting like he was hopped up on goofballs or something, right? But checked the level of valproic acid, everything looked normal. And I said, well, wait a second, let's check an ammonia. Sure enough, his ammonia came back super high. We all know, especially with like chronic liver like cirrhosis patients that have high ammonia, we know that can affect their mental status, and we know ammonia is neurotoxic. Sure enough, that was the issue. And so once we got his ammonia levels back down, he's back down at his baseline, right? So some patients are just more prone to that than others. The way you can prevent that is by giving a drug called levocarnitine. So I won't test on that, but that's just for your information. You can use levocarnitine sometimes as a prophylactic to help prevent those ammonia levels from spiking up. So again, looking at their therapeutic monitoring, this is another one we can get levels for. Usually for bipolar disorder, you'll see a therapeutic range of anywhere between 50 and say 125. Now, this one's not nearly as dangerous an overdose as something like lithium. So even people with levels like say 150, 175, 200 may not really be exhibiting a whole lot of significant side effects, especially if they've been at that level for a while and kind of adapted to that. So just be aware of that. And again, don't memorize the level, but just be aware that they may pop up on the test. You may need to make some decision about therapy based on what they're experiencing.
Does a patient with a lot of ammonia on board, does their breath smell like ammonia?
It does not smell like ammonia.
So they don't aerosolize it? Or?
That's a good question. No, it's really just on the bloodstream and the CNS, it seems. But again, that could be one of those things that's like, a lot of people don't think to check it, and so if you tell them to check that and it comes back high, you look like a rock star. So, FYI. Okay, another drug you can use for bipolar disorder, another common one, is going to be carbamazepine or Tegretol. Again, primarily used for epilepsy. This one's actually interesting because it's similar in structure to the TCAs, and so we'll see some of the side effects that will be kind of shared by both drugs. And again, for here, we don't know the exact mechanism for mania, not fully elucidated, but it affects lots of different receptors. Things like sodium channels are the primary way that it inhibits seizures, as we'll see when you get to the neurology section. But this can be useful for patients, not as a first-line therapy, like something like valproic acid, but say they fail lithium therapy. This may be a good backup drug. This one also has therapeutic monitoring associated with it, so here's the level that you'd be shooting for with carbamazepine. And so the adverse effects, and this is one of the things you'll see with all of the drugs for epilepsy, is that in general, sedation is going to be one of the big side effects. So ataxia, lethargy, nystagmus, they can all be potential side effects for a lot of these, because again, they're slowing down the brain. And so again, that's going to be a common side effect you're going to see with that. With this one, because it is similar in structure to the TCAs, you also can see some cardiac conduction changes risk for seizures, which is similar to that class. And then you also worry about hyponatremia, and this is going to be related to the fact that it can lead to the SIADH, or syndrome of inappropriate antidiuretic hormone secretion. So sodium levels would be one thing you can potentially track for your patients when you're monitoring them on this therapy. Okay. Big drug interactions you're going to see with this one is that it actually will induce CYP3A4, meaning that it can lead to increased metabolism of lots of drugs like anticonvulsants. It can affect your oral contraception to make that less effective. So just be aware of that interaction and check your med profiles before prescribing. And so interesting things you'll also note when we get, especially in the neurology section, is that a lot of these drugs can displace one another off serum proteins. And we know that the higher the fraction of a drug that is not protein bound, the more pharmacologically active it is, right? Because if it's bound to proteins, it can't really do much to the receptors. So as soon as you start to kick those drugs off the receptor or off the proteins, more of it's available in the bloodstream and have its interactions there. So just be aware of that as well. Yeah.
It increases the concentration of anticonvulsants or decreases?
So if the anticonvulsant is metabolized through CYP3A4, it can reduce those levels, right? Because it's inducing CYP3A4, but potentially, if you had, say, an interaction between valproic acid and this, if you were to kick one drug off of the protein, the level stays the same. You know, if I were to measure blood level, it's all the same amount of drug in the bloodstream. It's just a higher free fraction of it is available to interact with the receptors, right? So that'll be an important thing when we talk about phenytoin. Phenytoin, otherwise known as Dilantin, is a very common drug used for seizures and epilepsy. And so that one is frequently reported as being 90% protein bound, which means 10% unbound, right? So that 10% is the pharmacologically active effect. And so if you were to measure, say, a serum level, you're measuring all the drug in the blood, say a level comes back at 20, you can say, what is the free fraction of that? We know it's 10% of 20, which would be 2, right? And so if you would measure a free level of phenytoin, which you can also do, it would come back at 2 probably, right? So just keep in mind that by interacting with the amount of free drug that's not bound to the proteins, the more that is free, the more it can interact with the receptors, more likely you are to see side effects. We'll talk about that much more in depth when we get to the neurology section. You can also use oxcarbazepine or trileptal. This is a derivative of carbamazepine, but there's no therapeutic monitoring for this one. We don't have really any levels that we're monitoring. This one also is going to be blocking sodium channels, but for mania, we don't really know the full mechanism here. This one is also less data than carbamazepine, but also could be potentially used, especially if patients are refractory to other therapies. Similar adverse effects to carbamazepine, but this one actually has even more SIADH, so monitoring sodium levels is going to be really important for these patients. This one also can induce CYP3A4 and actually inhibits CYP2C19, so that can be important for your patients who say are like on warfarin, because that is one of the enzymes responsible for metabolizing warfarin. Okay, so another one, I'm starting to see this one becoming more common, but this is lamotrigine or Lamictal. This one has several mechanisms, but the ones important here are blocking sodium channels and also inhibiting glutamate release. You know, glutamate to be what type of neurotransmitter? Inhibitory or excitatory? Excitatory, absolutely. So by blocking glutamate release, again, it's going to have a similar effect as if we were increasing GABA activity. This one is nice because it actually has both antidepressant and mood stabilizing effects. So it can be kind of a dual mechanism there for your patients. This one has lots of drug interactions, so especially if you're mixing it with valproic acid. Valproate actually will decrease the clearance of lamotrigine. It can actually double its half-life. So in that case, if say you had a patient who had bipolar disorder, you're treating them with valproic acid, and you want to add on lamotrigine, you actually use half the initial starting dose because of the fact that the metabolism is going to be limited due to the valproic acid effect. That makes sense? I always see too high levels of lamotrigine. You see lots of problems with that. Namely, the problems being related to, you know, obviously you see the drowsiness and the tremor and whatnot, but the big thing with lamotrigine to watch out for is going to be skin reactions. Rash and pruritus can occur somewhat frequently, and you know, up to 10% of people are discontinuing therapy just due to the rash that develops. Again, most often this is going to occur when you add it on to valproic acid and they don't take that dose decrease into account. That's where we really run into issues. And then for very severe skin reactions, so say a patient starts developing blisters or starts having issues in the mouth as well, Stevens-Johnson is a potential risk. So again, patient who's on lamotrigine that start to develop severe skin reactions, that should be a good education point just to stop therapy, go to the ER to get taken care of immediately. So big risk with lamotrigine. Okay, so any questions on those drugs? Okay, moving on. Yes?
You said that valproic acid has synergistic effects with like carbamazepine, but isn't it like negative effects? Because you said that with the receptors, or is it not synergistic with carbamazepine? It's just other drugs.
So there could be some pharmacokinetic interactions, right? So you can have some issues to where one may be increasing the level of the other or decreasing the levels, but mechanistically they can have synergistic activities, right? So if you get the levels just right, by working on different receptors, they can have synergistic activity to work on the mood stabilization properties, right? So probably more frequently I see patients who are on lithium and something else, or valproic acid and something else. I usually don't see valproic acid and carbamazepine necessarily, but again, those are going to be more refractory patients. Like hopefully you don't have to get to that point where you need multiple mood stabilizers. Hopefully you can just kind of
Increase the dose of one, it would bump off the other one, is what you were saying?
yeah, potentially. Yep. Any other questions on that? Okay, so moving on to talk about the antipsychotics. So, we'll see therapeutically where you can use these drugs at, but we'll mention these specifically for how they are working on for schizophrenia as well. We will see that the first generation agents, these are the older agents, they're going to be working specifically by blocking the dopamine 2 receptor. Okay, so dopamine 2 receptor is the important one here. The second generation agents, which typically have fewer side effects, or at least different side effects, less severe side effects, I'll say, they're working by blocking dopamine 2 receptors as well, to a lesser degree though than you see first generation agents, but they also will end up blocking 5-HT2A receptors. So that's kind of the other big place where they have their mechanism of action. We'll talk about more specifically how those are working for schizophrenia later on in this section. We will see that these are frequently used for acute manic episodes. So these are for the patients who are a danger to themselves or others. If you need to knock them out quick, these are good drugs for that, right? Especially if they are having significant psychosis, aggression, agitation. These are all going to be really, really good therapies for that. And we don't necessarily use them a lot for long-term therapy. We're going to see there's lots of kind of chronic side effects associated with these drugs, things like weight gain, dyslipidemia, type 2 diabetes. But very frequently, it's you may see an acutely agitated patient who will either receive like a dose of say IM haloperidol or Haldol. That's a very good one. That's a first generation agent you can use to sedate someone pretty quickly. Other things you can see, some of the second generation agents like ziprasidone or olanzapine, they have IM options available that you can give. And why do you think IM is the best route for those patients?
They're too wild to start a line.
Yeah, so some of these patients are going buck wild. Giving them anything orally, they're going to spit right out back at you. Getting them an IV started, it's going to be pretty tough. IM shot, it's going to be your best bet. Sometimes if you like just aim it right, you can lob it across the ED and just nail them right in the delt. So because again, they can be very, very dangerous in some cases. And so usually, hopefully they're in restraints if it's need be, and give them the shot a little bit easier. But they can be a threat to staff as well. So just be aware of that. We'll talk about the adverse effects and drug interactions in the schizophrenia section, but just know that these are better for acute manic episodes, mainly because they have really good sedative properties. It'll just basically kind of knock your patient out, kind of get them settled, and then you can tune up their normal mood stabilization therapy and get them back on normal maintenance therapy to kind of get them back at a baseline. Okay, and some other alternative agents you might see being used in bipolar disorder. So, benzodiazepines can be useful. We'll talk about these in the anxiety section. We'll also talk about these in the neurology section as well. Benzodiazepines, can anyone think of some examples? Valium's a good one. Diazepam, Ativan, which is, it's Ativan, yep, it's lorazepam. Very frequently, I would end up seeing patients. They call it get some vitamin A. Or vitamin Ativan. So you have an acute manic patient, you can give them a dose of haloperidol and vitamin A, some Ativan, and that would knock them out very, very well if they were particularly aggressive. So this can be useful for the acute mania, for agitation, panic, insomnia. These can all be useful drugs for that. So they can be used for patients who cannot tolerate mood stabilizers for whatever reason, but that's usually pretty far and few in between. We'll talk more about those agents later on in this slide set. Potentially, you could also use some calcium channel antagonists. Some of these are thought to work against some neurotransmitter release and synthesis. You may actually find that verapamil, which is what type of calcium channel blocker? And non-dihydropyridine is going to have some mood stabilizing properties. And then we also see that another one, nimodipine, Can you guys guess which one that is? What kind?
Dihydropyridine.
That one's a dihydropyridine, yeah. Sometimes we actually use nimodipine for patients who have had strokes, and sometimes they'll have some vasospastic issues after the stroke. And so this one is good because it crosses the blood-brain barrier and has some anticonvulsant activities, and actually can help mediate some of the vasospastic activity that goes on post-stroke. So sometimes you'll see it used like in a neuro ICU type setting for that, but it may have some mood stabilizing effects as well. So general strategy, so start with a mood stabilizing agent, and this is more for patients who are not having like an acute aggressive kind of manic episode, but you can start with lithium, carbamazepine, valproic acid. Probably valproic acid is going to be your go-to one just because it has the fewest side effects. It's kind of best tolerated out of the bunch. You know, especially if they're having a lot of anxiety, agitation, insomnia, you can consider adding on a benzodiazepine. And then oxcarbazepine can be kind of an alternative option just because it has less kind of evidence for use and less experience. For patients who have severe manic episodes, you may need to start 2 agents to really kind of get them back to a nice baseline, and then you can kind of start tapering one drug or another based on how they respond. And then if they are having an inadequate response, that's where you can use, say, a lithium plus anticonvulsant or a second-generation antipsychotic. You know, we'll talk about that list a little bit later. Or you can use an anticonvulsant plus another anticonvulsant. So that's where you can do, say, valproic acid plus lamotrigine, or, you know, valproic acid plus a second-generation antipsychotic. So that's your general rule. Start with one agent if you can, and then you may need to add on another one, but make sure you're using kind of complementary mechanisms of action there. Does that make sense? All right. Okay, so that's it for bipolar disorder. Any other questions? Okay, I think I'm going to cut it here, give you guys a nice extra 10-minute break, and then we will continue on Thursday. I'll see you guys then.